Hi, good afternoon, everyone. We're going to get started soon, so if I may invite the speakers and the panelists to come up and join us. You guys have seats. Professor Sakamoto and I will be happily standing around and walking around. So we are going to start on the dot, but maybe just to give a quick preamble, this is a Abbott-sponsored lunch symposium, and it's called Mastering Mitral TEER. And I think particularly relevant, especially within Japan and the rest of Asia, there's been great familiarity with the mitral TEER. And I know that in Japan, you'll be launching TEER. So this is a great segue into what we want to do. Now we are exactly at 11:50. So let us start. My name is KKU. I'm from the National Heart Centre, Singapore. And it's a great honor for me to be here at Tokyo Valves again. And co-leading this with me is Professor Tomohiro Sakamoto.
Yeah, from Saisei Kakamoto Hospital. Thank you.
And we have four esteemed panelists, Dr. Mehdi Eskandari from King's College London and just moving to Melbourne, Australia. Professor Rafi, sorry, I probably can't pronounce your last name, Bankarajan. From Stuttgart, Germany, Professor Do Yung Kang from Asan Medical Center, Seoul, Korea, and Dr. Natalie Monterello from South Australia. We have three speakers, Professor Makoto Amaki, he's right there, from Osaka, Japan, NCVC, Dr. Yusuke Enta from Japan, and Dr. Wong Nian from Singapore. And Nian, can I invite you to come up here as well? I think we have one more, and Yusuke is Yusuke here? Maybe he can join us up here as well. Mm-hmm. So the learning objectives for this session is to understand the new 2025 European Society of Cardiology Valvular Heart Disease guidelines and how it applies to all of us in Asia in terms of practice, and also to explore the treatment for patients with ventricular FMR in the setting of heart failure outside some of the boundary conditions for the COAPT trial. And now with the greater experience that we have in Asia, how some of the more complex anatomies are addressed with the experience of our colleagues here. And perhaps to get a sense of who our audience is, can I get a sense of how many of you are interventional cardiologists? A raise of hands. Interventional, okay, a good number. Echocardiologists? Okay, great, about a third of the room. And for those of you who do everything, heart failure specialists? Heart failure specialists? Okay, a few. Okay, good. So we have a majority interventionals, maybe a third echo, and a smaller proportion heart failure. And I think this is perfect for us to go into, okay, Natalie's looking at me like, okay, don't make me feel bad, but maybe with that, it's a good way to start. And the talks are arranged such that we will have a talk, a case, followed by some discussion, followed by the continuation of that first talk, and then more discussion. So 3 talks, 90 minutes. It is meant to be interactive. If any of you have got questions, comments, panelists, please ask. You can use the app, or you can just speak up directly into the microphones that will come to you. So with that, let us launch into it. We have 10 minutes for the first part. Can I invite Professor Makoto Amaki to come up to do his case presentation on managing severe heart failure beyond COAPT. Makoto, please.
Thank you, KK, for the kind introduction, and Makoto Amaki from Natural Cardiovascular Center, Osaka. So I'm going to talk about the ventricular functional mitral regurgitation and beyond COAPT trial. So ESC guideline has been published last year, and you all been familiar. And we're going to focus on the ventricular functional MR. And if you look into the ESC in comparison to the previous guideline, note that it's the first time to class 1 indication for ventricular functional MR. It's jump up from 2A to class 1. It's a big leap. I think this is going to impact the clinical decision. But if you dive in on the guideline, it just say that clinical and echocardiographic criteria fulfilled according to the heart team. So what is the clinical and echocardiographic criteria? This is the table showing that clinical suitability, and you can see that end systolic diameter should be less than 70. No end stage heart failure patient, stage D, which is reflected by the COAPT study. But then how often do we treat COAPT in eligible patient? In STS registry and URSMR registry, around 40% of patients are COAPT ineligible. What about the prognosis of the non-COAPT COAPT ineligible patient? As imagine, non-COAPT patient did not respond to TEER therapy comparison to COAPT eligible patient. Similar in URSMR, the COAPT eligible patient respond much better than an ineligible patient. But in URSMR, if you look into the 6-minute distance walk, even with a COAPT ineligible patient, they do have a better outcome after the TEER, and also the quality of life do respond with TEER even with COAPT ineligible patient. Another report last year by Gilbert showing that in expanded registry, showing that the COAPT-like and non-COAPT-like patient had similar all-cause mortality and also a similar heart failure hospitalization. Looking to why does this happen? Looking into the MR reduction after 1 year, 90% of the patient in expanded registry, both in COAPT and non-COAPT patient, have a MR less than 1+. So this might be the difference between the previous registry and this current expanded registry. So maybe even with a functional MR, mitral regurgitation should be less than 1+. So let me show you 2 cases of a ventricular function MR. First case is a 22-year-old male, dilated cardiomyopathy. 8 years ago, he was referred to for LV dysfunction. Biopsy was done, and chronic active myocarditis was diagnosed. Started guideline medical therapy, additional with immunosuppression therapy. After reducing the immunosuppression therapy, inflammation worsened, and he is still on the prednisolone and cyclosporin. 4 years ago, LV dilatation progressed from 66 to 80. Functional MR worsened from 1 to 4+. BNP rose from 100 to 2,000, and the dyspnea worsened as well. So mitral clip was considered. In social background, he lives with her mother and limited financial support. And the medication was fully dosed, but his understanding of his cardiac situation was poor. The compliance of the medical therapy was very poor. Looking at the echo, we can appreciate the severe left ventricle enlargement, reduced ejection fraction, and severe mitral regurgitation. So heart team discussion was done. He is a young patient with the juvenile DCM. NYHA 2, but progressing from stage C to D. Non-COAPT phenotype, uncertain benefit from mitral intervention with TEER. He's a young age, so heart transplantation should be considered, but limited family and financial support. And also, his poor understanding of disease and suboptimal medical adherence. We then discuss, and due to a social and adherence limitation, transplant candidacy is currently difficult, and aim to continue optimal heart failure management with the current therapy as long as possible. Let me move on to the second case. This is a 57-year-old gentleman diagnosed cardiac sarcoidosis. 12 years ago, the patient was referred to LV dysfunction. The ejection fraction was around 30. Posterior wall aneurysm and positive PET and finding led to a clinical diagnosis of cardiac sarcoidosis. And platelet was started. After that, non-sustained VT occurred at the same year. ICD was implanted. Since then, patient had no heart failure exacerbation, but he had a multiple time VT occurrence. Despite medical therapy, LA and LV dilatation was observed, and patient was admitted to our ward. Again, this patient also had a severe LV dysfunction and enlarged LV with a DDDS of 91/86, severe MR, and observed as a functional. And also, he did have a P3 prolapse, so it's a combination between combination of the DMR and functional MR, as you can see in 3D MPR. So heart team discussion for this patient. Patient was isolated cardiac sarcoidosis refractory to optimal medical therapy. No evidence of left ventricular remodeling despite treatment with a non-COAPT phenotype. Patient is a candidate for transplantation, but refused heart transplantation because, well, in a lot of conditions that he didn't want this treatment. So we had to continue to the conventional therapy, including the mitral clip. So a summary of these two cases. Case one is a 22 years old with a DCM. Case two is a 57 years old male cardiac sarcoidosis. Yeah, and both of them are in class 2B class.
Thanks very much, Makoto. I think great cases to illustrate some of the challenges. So if I can invite you back to the stage here. So heart team, what do you guys think? I think Natalie, as a heart failure specialist, could you advise us what your thoughts are on both cases? Maybe we just focus on the first case, that young patient with the dilated cardiomyopathy.
Okay, thank you. So I agree. I think the first point that we've got a young patient we have to think about, is this patient a transplant candidate? And at the moment, for many reasons, and I think compliance is the main concern that I have, he's not a transplant candidate. What we do know from things such as the mitral bridge registry, though, is that this mitral clip can be used as a bridge for transplantation, for stabilisation, so we can improve him hemodynamically, so we can hopefully optimise heart failure pharmacotherapy. We can buy him time for introduction of compliance and education about his disease, which was one of the concerns that was expressed. And what we saw from a mitral bridge registry was this cohort of patients. They were younger. I think the mean age was around 58. They had severe LV impairment, and 80% of the patients in the mitral bridge registry actually don't meet COAPT. So it's exactly the patient you've been discussing. And what that actually showed was about a third of those patients, after going mitral edge-to-edge repair, were adverse from major events at 1 year, being that of hospitalisation for heart failure, being that of death, being the need for VADs, being for the need of a transplantation. And it also showed that around 23% of these patients who were actually put up for transplant were taken off the transplant waiting list. So I think for this patient, if it was technically feasible, I think it would be a very reasonable approach to discuss them, to buy us time for education, hemodynamic stabilisation, for up-titration of heart failure pharmacotherapy, and potentially even the need to take him off the transplant waiting list in the short term. What I think is important to recall is that this is a 22-year-old. This is not a long-term fix. And unless those other strategies can be employed, his long-term prognosis is very poor.
Thanks. And for the audience, if you have any comments, please just do raise your hand, chime in, grab the mic. Maybe I can ask the interventionist on the podium here. Would you, in your practice, offer this given the dilatation of the LV today? Rafi?
So I certainly would offer the patient mitral clip implantation, because it will be difficult for the moment to up-titrate in a compliant way the medication. Of course, normally that would be the way to go, and normally we would first expect the patient to take the medication, but as we saw, this didn't work in the past, and it won't be happening so easily. So to buy some time, as you just explained, and also to stabilize the patient who has an extremely poor prognosis in this current situation, I would definitely offer a solution with a mitral clip implantation.
Doyun?
For this young patient, I think for two guys said that the bridging therapy to this poor patient, I think that the mitral could be a clear benefit with a less invasive approach. I would suggest for the patient.
I have a slightly different question, maybe for the imagers on the panel and perhaps in the audience. Do you think that the images shown, I don't know whether we can go back a little bit for the dilated cardiomyopathy case, are there any technical aspects to be worried about in that specific case? Mehdi? Can we go back on the images? Okay, I'll let Makoto handle that.
And I might have missed, but I'm not sure if you had quantification of the LV volumes and the EOROA and the usual quantitative methods for MR. Those also could be helpful. And I think the assumption was that the RV was also normal in function, and I don't think that I saw the right heart catheterization. That type of stuff will help to make a formal decision. From the images that I can see, pretty good quality TTE images. They're all with color, but the posterior leaflet, as you would normally imagine, is slightly short and restricted. It is a slightly posteriorly directed mitral regurgit, pretty broad in that apical two-chamber view on the far right on the top. Looking at the TOE images, again, the color is on. I tend to take the color off after finding the severe MR to look at the length of the leaflet, quality of the leaflet. But again, in the bottom left, in the LVOT view, you can see that the posterior leaflet looks very short there to me, to be honest with you. I'm not sure if you have any measurements. So technically, this is going to be challenging with a broad jet and a relatively short posterior leaflet. Other measurements that often helps if you have the essentially annular dimensions, that would be helpful. If you have very dilated annulus, that might inform you in terms of the choice and the type of device. And there are some other measurements that you could do, but it would not really change your technicality, more about the outcome, including the tenting area. There are some other measurements, including there are many measurements have been proposed, including the leaflet area divided by annulus. Those are more related to the outcome rather than the procedural success. So technically, I think it's a short posterior leaflet, and I would call it challenging.
Okay, maybe just to I think Dr. Wong has a comment, but I would like to ask Dr. Wong and Dr. Yusuke. In this case, you have seen the 22-year-old dilated cardiomyopathy in anatomy. Anatomy is doable, but exceeds COAPT conditions, short posterior leaflet. Will you be able to do it in your institution? Maybe Yusuke first?
Yeah. I choose the mitral clip NTW or NT, a short type mitral clip, because the leaflet thin is very thin, and not to the leaflet length is sufficient. Then I choose the short type clip.
Okay. Ningen?
Note that the PML length is a 14.
14, okay. So you had a comment, and maybe will you be able to do this in Singapore?
I think the anatomy-wise is not an issue for a TEER. I think the biggest question is actually the indication for the procedure. I think this slide summarized this very well. This patient has really severely dilated cardiomyopathy and also severe functional mitral regurgitation. The overall prognosis is governed, I think, in this case by the LV dysfunction. Yeah. But his clinical situation, his challenging social circumstances is the reason that make us consider TEER for this patient, because his cornerstone of therapy is still going to be guideline-directed medical therapy, and if that fails, it's going to be advanced heart failure therapies. But his social situations limit that. And that's why TEER is a reasonable consideration in this case to hopefully like what was mentioned, to help him gain better understanding of his condition, to buy time for medical therapy optimization, and give him an option and some time to actually get these things better. So he and his mother need to really understand that this TEER is not going to cure him for the longer run. Yeah, it's going to buy him time, make him feel a bit better, hopefully, and medical therapy, advanced heart therapy in the long run is what will get him going.
Okay.
So in this specific case, so young lady, so I think the transplantation is the best option, therapeutic option. But in this specific case, we have to choose the mitral clip in this case. But after the mitral clip, so Makoto, do you have any future option? I mean, the remodeling, the LV, after the remodeling LV, so we can choose some surgical option or something like that?
Well, yes, given the size of the LV, and we're not that optimistic about the reverse remodeling after a TEER. We were thinking that since he was 22 years old, but his mental status is not as close to 22. It's about like 15 years old mental status. We need to teach him how the condition is. We need to proceed to prescribe the medicine more, and we need a time. But since the situation was not as, the situation is very, very critical for this patient. So I think we need to have more time by intervening with a mitral clip.
Okay. Thanks. This case alone has taken us quite some time, but we have another case, the sarcoid case, a slightly different texture. Maybe to hear from everyone again, what are your thoughts? The LV is much more dilated, 89, right? If my memory serves me, 86. Okay, close enough. Thoughts? Maybe I'll invite Natalie again to go first.
Okay, so the two things for this case that I think is important is first of all, he's asymptomatic from a heart failure perspective, and I think that's really important. And the second thing is I want to know what's actually happening with the right ventricle. So from the asymptomatic perspective, I actually want to find out if this patient truly is asymptomatic, and I think that's when we can utilise things such as valve stress echoes and make sure that this patient doesn't have symptoms, because that changes, for me, the indication for this patient to go ahead to have a transcatheter valve intervention. That, I think, would be important. We can also have a look what happens with the pulmonary pressures, look for symptoms, look what happens to the LV, contractile reserve, and that might push me towards more doing intervention in an asymptomatic patient. What I think is important, however, is we also address the RV, and I think very commonly we forget the RV. And I think that if this patient has severe RV dilatation, if they have severe RV impairment, they have significantly elevated pulmonary pressures, and this is an underlying cardiomyopathic process, I think fixing the mitral valve is not going to fix the patient's overall prognosis or their heart failure. And I think that's something very important to consider. And I think looking at things such as your RV stroke work index, looking at RV-PA coupling with right heart catheterization should be utilised probably more than we do. And so they would be the two things I'd want to address first, which I think would guide my decision-making about whether I thought this was a suitable candidate for transcatheter edge-to-edge repair.
Okay, well, we do have a bit of, we are slightly behind time, but maybe I'd like to invite all of you here on the panel. There's one echo, one heart failure, and everybody's an interventionist. How many of you would offer, because the LV is dilating, is this enough for you to offer? But it's of course not a COAPT patient. The LV is not, patient has got no symptoms, or would it be enough? Maybe just so that we can let Makoto present. How many of you would offer TEER? 1, 2, 3. Okay, 3, but not quite the majority. Okay, now Makoto, over to you. Tell us what you did with those two cases.
So with the first case, as I told, he needs a time to understand his situation, and he needs a time to optimize the medication. And so we decided to go TEER procedure. We thought that it's a simple TEER procedure because the jet is centered, and we just, since the posterior leaflet was 14 long enough, so we chose the XTW, although there's always a risk of a tear with a severe LV dilatation. We gently grasped, but there's a difficulty in leaflet insertion, especially on the posterior leaflet. And we tried for several times, but we couldn't insert as much as we could, like this in the image on the left side, on the right side. And we decided, we noticed that there's a posterior membranous tendon that was interfering. So we have to grasp with less insertion, but still it was optimal at this point. And there was some residual MR on the medial side, as you can see here, but we thought that this was the maximum volume reduction, and we couldn't put another NT device because of the membranous tendon. And this was the 1 month after TEER, and mitral regurgitation was mild. And he improved the symptom, and no heart failure after 3 years. Then move on to the second case with a 75 years old cardiac sarcoidosis. The major target at the first point was the DMR part, which was on the P3, A3 with a PC, which was a bit wider, like about the 12 millimeters. So we selected NTW. With NTW, the insertion was optimal, and we grabbed the leaflet, and MR was reduced. However, the functional aspect remained, and it was still 3+. So we have to deal with this. Using XTW in the center, we could reduce mitral regurgitation to mild after the grasping in the center portion. In this case, after 4 years, he didn't have any single heart failure admission. And note that at the LV size changed from the baseline to 6 months, 1 year after. It's gradually going down, and after 4 years, it is still going down. The medication didn't change much with this patient, so it clearly is the mitral clip has the effect on reverse remodeling. So how can we detect MTEER responder in these kind of very severe non-COAPT patient? One aspect is we have seen the right heart catheter might be the key to determine these patients. PA compliance, one of the RV afterload measurement, might be the key, and it's been reported in a severe heart failure patient. We investigated in an MTEER patient, and we noted the PA compliance more than 2.7 had a better prognosis comparison to the less than 2.7. What is the PA compliance? It's the pulsatile afterload of the right ventricle. And it's been, the equation is systolic stroke volume divided by the difference between the systole and the PA diastole. And it has been shown that the PA compliance is a strong and independent predictor of the mortality in patients with the pulmonary hypertension, better than a PVR, and it decreases earlier than a PA pressure or PVR was normal. So case 1 and case 2 at the right heart catheter is shown here. What is the PA compliance? Although his PA pressure is high, wedge is really high, low cardiac output, but the PA compliance is 3.7. What about the second case? Again, PA pressure was not high, but this output was very low. 1.8. Cardiac index by dialectic was 1.8, but the PAC remained 3.6. So both of them is over 22.7. So it clearly demonstrates that these patients do respond to this TEER. So my take-home message is number of patients, COAPT ineligible patients are treated with TEER. Non-COAPT-like patient may benefit from TEER, and right heart catheter parameter may differentiate who benefit most in non-COAPT patients. Thank you very much.
Thanks, Professor Maki. So really nice demonstration or illustration of some of the more complex cases that I think we all agree will cause us headaches in the heart team. Do we or do we not treat? But if we don't treat, then the patient really has no real good option. These patients benefited from expert therapy, and I think they are illustrative of how perhaps we can push boundaries a little bit, but at the same time respecting that this is a heart team effort. So maybe with that, we can move on to our next presenter.
So yeah, let me introduce the second speaker of this session. The second speaker is Dr. Yusuke Enta from Sendai Kosei Hospital. So he's an expert of the mitral clip, especially in case of the very complicated cases. So please start your lecture.
Thank you, introduction. I'm Yusuke Enta from Sendai Kosei Hospital. Thank you very much for the opportunity to present. Today, I will discuss our experience using the mitral clip G4 system in complex and non-central MR and explore how device evolution allows us to approach anatomies that were previously considered challenging. The fourth generation mitral clip G4 system provides several important technical advances, independent grasping and improvement deployment sequence, and expanded size options. The introduction of the mitral clip G4 system has enabled us to address complex cases with greater confidence and achieve more consistent MR reduction. Yeah, let's go on complex case. This is a 90-year-old male with severe DMR due to an AC and A1 failure. Despite advanced age and high surgical risk, the anatomy was suitable for transcatheter intervention. However, lateral non-central regions are technically demanding. This is a TT image. Left ventricular function is preserved. In the parasternal view, the MR jet is directed from the anterior to the posterior wall of the left atrium. In the three-chamber view, we also observed on anterior to posterior MR jet. In the apical two-chamber view, the MR jet expands from lateral to medial and appears localized to the A1P1 segment. In the long axis view, the jet again travels from lateral to medial. Overall, this represents to lateral A1P1 region, predominantly involving the A1 side. This is a T image. We identified a flail involving A1 and the anterior commissure. The flail width was 6 millimeter and the flail gap was 4. The EROA was 0.6 square centimeter, consistent with severe MR. The posterior mitral leaflet length was 10 millimeter, which was sufficient to proceed the TEER. Yeah, this is a clinical summary. This is a 98-year-old male with severe DMR due to AC A1 failure. Despite advanced age and high surgical risk, the anatomy was suitable for transcatheter intervention. Then, given the ACA1 lateral target, we selected the mitral clip. Return to the chairman.
Yeah, thank you, Yusuke. It's a nice talk. So, in this case, so the non-central DMR case, so you choose mitral clip, the XT, is that right? So, So as a panelist, so how in your practice, so how do you treat in this patient? So okay.
Well, this is truly challenging. So as you get towards the commissures, obviously, even in normal valve, the length of the leaflet gets smaller. The subvalvular apparatus, which is relatively less crowded in the center of the valve, becomes more crowded with the cords of pap muscles coming to both leaflets. And therefore, the chance of getting entangled within the subvalvular apparatus is high. And if that happens, then coming off with a wide and tall device would be very difficult. So for that reason, XCW is a relatively brave call here. Although some operators try to go in the commissure, and maybe a smaller device would be a better choice, in my opinion. As I said, you could use it, but based on those anatomical characteristics we are seeing, and the leaflet looks in some views short. One point about the TTE was that it was a standard TT, a standard parasternal, a standard apical views, which would not show you the landing zone for a commissural view. If you want to interrogate that in TTE, you have to, in the parasternal view, clock and counterclock towards the 1s and the 3. And in short axis view, you can actually use your biplane imaging. Because those views that you see, the leaflets are relatively good quality and long. In my opinion, they are not exactly where the actual jet is. The TOE is more informative, and the leaflet is short, so I would advocate for probably actually short device, maybe wide.
Okay.
So it's quite interesting to hear the differences in opinion, but that's exactly some of the hard team discussion on the technical side. Ningen, I think you wanted to jump in. Go ahead.
I think in the past we used to feel that A2P2 is the simpler lesion. Yeah, it is a more straightforward kind of TEER anatomy. But nowadays I find that actually the commissurers are actually pretty nice to treat because if you close off the commissure, you actually eliminate the mitral regurgitation. But for the A2P2 pathologies, if there's some slight change in orientation, you can actually cause distortion and you have more MR jets adjacent to it, and it can be quite a tricky scenario to treat for A2P2. I think one of the difficulties in the past, I guess, for treating this commissural lesion, not just the core subvalvular apparatus, is that in the past we used a lot of 2D imaging. Yeah, and when 2D imaging explained across the intercommissural view, you don't truly get the commissure. You really, really need to use 3D multiplanar reconstruction imaging to really get the commissural pathology and to align the clip perpendicular to the line of coaptation to address that. And if you get nice 3D imaging, 3D MPR imaging, and you put a clip there and close out the commissure, you can really eliminate MR and get a very satisfactory result.
Okay. Rafi?
So I think a very basic discussion is maybe necessary in this patient because this is a case with a realistic chance of ending up without any clip in the end because you might get some stenosis or a completely insufficient result. So the first question would be for me to see, is this a patient who is expected to get a gain in quality of life? He's a 90-year-old frail patient. If we have the feeling that even a good treatment of the mitral valve will not change a lot in his quality of life, I would be even hesitant to perform the procedure. However, if this is an active person who enjoys life and who might actually gain quality of life, then of course we can do it. If we do it, we have to consider that we will not get the perfect result most likely. I personally doubt that a commissural clip will be possible, but maybe I'm wrong. And we will see in a few minutes maybe. So normally I would aim for a more central clip, reducing the MR, but not getting a perfect result maybe.
Would you, if you had to choose, use a short or long clip?
A short.
Short. Do-yoon?
For me, actually, I would prefer the shorter one because it is commissural. So there can be some interaction between the lateral walls and the codas. So I would prefer the clipping a shorter one with a very commissure, and then consider to add one more if there is some residual regurgitation. And I would ask the operators that how about the angle at the commissure? Would you still be on the 0 to 6 o'clock approach, or like apply another angle?
We can discuss that in a while. So the question, of course, is it a vertical 12/6 or a slightly angled along the the line of coaptation. But before that, maybe to ask Makoto, a short or long clip?
Yeah, depending on whether the AC, where the commissure is attached to A1 or not, we would definitely, if the AC is attached to A1, then I would go for a longer arm, aim for A1, P1. If the commissure was dominant and it seems like there is a different gap between the AC and A1, I would choose NT. Having said that, I might not be able to get another clip besides, but I would try to go for NT first to eliminate the portion of the AC prolapse, and then I would think about another second clip. It might be XT or NT.
So a bit more of a complex discussion, and there are publications looking at the role and the relative sizes of the commissure as well as the posterior leaflet, and in this case, the relationship with the anterior leaflet. So I think that one deserves a lecture in of its own, but you have heard some of the opinions. I can't help but ask the audience, can you tell me how many of you would choose a short clip? Short clip? Come on, raise your hands if you agree. Short clip, okay, at least half. A long clip? Long clip, anyone? Okay, one brave soul. Sir, can I ask you why you would choose a long clip? You want to maybe share your ideas with us? If there's a, oh yeah, that's the ball here. Okay, I don't dare to throw this. I might just hurt someone, so I'm going to walk to you. If you don't mind, could you tell us why you chose a long clip?
Thank you for this opportunity. I belong to the hospital same as Dr. Inta, so I use long clip.
Why do you use a long clip?
Yeah.
Why would you use a long clip for this case?
I belong to the hospital with Dr. Inta, same hospital.
Oh, same hospital. Okay.
So I use long clip.
I think that's a very good answer. Okay. We have a little bit more time for. Okay, we have a little bit more time for discussion. So the second question that was asked that Do-Yoon had asked is, do we go vertical 12/6 or at a perpendicular angle? Maybe because it's also a complex question, I'm going to ask the panelists here. Maybe, Mehdi, would you say?
So for that one, I definitely, as the other panelists mentioned, use the multiplanary reconstruction because
MPR.
it's very difficult to say from this on-fast view where that coaptation line ends and whether we are actually dealing with a commissural segment, or this is a part of A1 as you mentioned. And that only, in my opinion, is doable when you do proper MPR of color and then analyze the valve. If it's truly commissural, if it would come alongside the coaptation line, is impossible because the concept of the edge-to-edge then won't be practical. But if it's part of the essentially P1, then we all have done cases similar to this, that either short or long. That's a technical question, but it's doable. Sometimes if you get the pathology right, it would be a significant reduction, and one device even may be enough.
You know, we could discuss forever on that as well, but I know Dr. Yusuke told me he needed more time because I think he must have had an interesting case to experience with that case. So I'll let him discuss, then we can come back to the discussion. So Yusuke, please.
I recommend him that non-central DMR is suitable for mitral clip XT every time. Yeah, next slide. This is a procedure video of the case. Subtitle is Japanese. We discuss intra-procedurally how much clocking is needed in close coordination with echocardiography. Again. Sometimes the echo specialist says just to rotate more clockwise. No, stop that. Or 5-degree rotate. We cannot 5-degree. But, and of course, we should follow her. The mitral clip is then advanced into the left ventricle. Even in a confined space, the narrow device allows greater maneuvering within the LV. because this is a DMR with preserved E-health, the LV motion is significant, and the entire device tends to be pushed towards the center. However, the straight line derivability of the mitral clip allows it to advance directly towards the intended target without being displaced by LV motion. I believe this is one of the key characteristics of the mitral clip system. With them, open the clip, the opening angle can be adjusted in a narrow space. We avoid full opening and instead expand the arm more widely just below the leaflet where there is sufficient room. The ability of gradually control arm expansion is anterior important features of mitral clip, especially in confined non-central PMR anatomy. Once leaflet insertion into the arms is confirmed, we close the clip. Active closure helps maintain high closing force. From closure to release, the device demonstrates stable behavior. These are the pre- and post-procedure TE images. The mitral clip XT was deployed at the A1P1 segment, and the MR was disappeared. At the two-year follow-up, MR reduction was maintained, demonstrating durable leaflet coaptation even in the challenging anatomy. Even in non-central primary PMR, the performance of the mitral clip system remains strong. In particular, with the introduction of the G4 generation, its capability have further expanded. Non-central DMR, especially lateral regions such as A1P1 and the anterior commissure, requires stable advancement towards the target while resisting left ventricular motion and avoiding displacement towards the center. Mitral clip's superior straight line derivability enhanced maneuvering the precise target access. Longer arm, XT, XCW provide greater resistance against LV pressure, contributed to sustained MR reduction and long-term control. Higher closing force also supports durable MR control. This is our center study. 129 patients were identified as having primary MR. Among these, 38 patients had non-central PMR. Traditionally, non-central MR has been considered anatomically more challenging. However, in our analysis, non-central regions were not inferior to central region in terms of MR worsening. In fact, when we focus especially on the rate of MR recurrence, the non-central group tended to show even better outcomes compared with the central group. Kaplan-Meier analysis at 1 year suggests to favor tend in the non-central cohort. Although technical demanding these anatomies should not discourage us from intervention, challenging anatomy does not necessarily translate into the inferior durability. Long-term durability may be supported by the higher closing force of the mitral clip system, which helps maintain stable and sustained leaflet coaptation and continuous LV pressure. We compared peri-procedural and midterm events according to the clip type. The evaluated endpoint included failure to deploy and residual MR during the peri-procedural period, SLDA and MR recurrence at 1 year. Notability, short-term NT or NTW such as NTW were associated with higher rate of peri-procedural SLDA, residual MR, and recurrence MR during follow-up. Although longer arms might increase the risk of leaflet injury, such as leaflet TEER, the use of G4, XT, and XTW appear to contribute to more durable long-term MR control. We speculate that the longer arms provide a firmer and deeper leaflet grasp, allowing the device to better withstand continuous LV pressure. In addition, with the G4 system, features such as controlled grasping CZA enable deeper leaflet insertion, which may also contribute to improved durability. This is the Ocean mitral registry clip selection. The use of longer arm clips was associated with a higher rate of MR control at 1 year compared with short arm. TEER should not only be viewed as MR reduction. It is also a strategy of left ventricular pressure management. In central DMR, distributing stress with 2 clips and using longer arms may improve durability. In non-central DMR, edge positioning and straight line deliverability are essential to reduce leaflet stress at the motion. TEER is not simply about reducing MR. It is about management leaflet stress and continuous LV pressure, my message. This is conclusion. Thank you.
Thanks very much, Dr. Yusuke. So I'm really interested because it looks like your strategy at a center level is to use the long arm, but you saw just now that the majority of the audience will use a short arm. Can I ask what your thoughts are? Oh, I think you want to go back on the slides. Is it? You want to go back on the slides? Or? But can I ask Dr. Yusuke, and how did you come to that conclusion? Was it because of experience that you say that maybe the longer arms, how can you avoid distortion of the leaflets, and how do you, because the long arms is an issue, and also how do you avoid getting entrapped in the caudal structures that are more prevalent in the commissures?
We avoid the TEER and tanglement, and to avoid the tanglement and SFDA and leaflet TEER, we check the orientation and trajectory again and again prior to MTEER mitral clip to the progress to the LV.
I see. So the trajectory as well as the orientation. Any comments from our panelists? I think it's an amazing result, Makoto.
Yeah, with regards to this data, I would say there's a patient selection bias, because if you choose NT, it can be very lateral, very commissural region, and can be very difficult situation. That might affect the unable to deploy or residual MR. So we can't just say that NT is not as good as the XT, depending on the anatomy. And I would say NT is really, really powerful, especially with this commissure lesion.
I think that's a good point. Do-yoon?
Still, we should have caution to interpret this data, because the G2NT is the older generation and the early period of the procedures. So we should interpret this data with only G4 data. And we can see that the recurrent MR is the low in NT. That would be more, I don't know the exact data, but it would be related to more commissural region, like that Makoto said. And the XT or XTW can be used in the more central region and more the patient with a more large degree of the prolapse. Then those regions usually recurs on progresses with the time. So I want to just ask one more question, that the patient with the large prolapse and then very close with the XTW or XT, but still the MR degree is 0 or 1, but still there is some prolapse. Then would you treat more for long-term result or stop there?
So there's a slight different question now, but I want to summarize the discussion points from Drs. Amaki and Do-yoon. One is that these results show that the not so good results with the older systems, and I think that's important to appreciate. and that any retrospective studies would have the likelihood of some perhaps unclear confounding factors or undescribed factors, and there will be some intrinsic selection bias. So I think very good points from our panelists. To Dr. Yusuke and the panelists and Dr. Sakamoto, there was another question. If you have reduced MR and there is still residual prolapse, will you go after the residual prolapse as long as the gradient allows for it? As long as the gradient allows for it, would you go for the residual prolapse? So maybe we'll make it, we'll let people give their opinion, and then we'll ask for a vote. So MR has gone to 0, but there's prolapse. Dr. Wong, would you? I know his answer.
I think anyone who does TEER with me knows that I can't accept residual pathology. Yeah, I think if there's residual pathology, that needs to be addressed, because we are now not looking at just short-term outcomes of mild MR reduction. We're now looking at 5 years, 10 years. The patient needs to have durable results, and we may be treating even younger patients in the future, we don't know. So durability is very important, and we see that if there's residual prolapse, we see them in clinic, they do recur. Yeah, they do recur over time because this residual prolapse adds some form of redundancy and stress to it, and leakage can occur adjacent to it. So even though there's no MR or mild MR, I would still push for a second device to hold it there. I think the question sometimes is redundancy, but no residual pathology. Then that was a much difficult question. But if there's residual pathology, I think I'll address it, just like the surgeons would definitely get it addressed. That's my opinion. But they'll hear from the rest.
Dr. Raf?
So it actually depends a little bit on the size of the prolapse or if it's a flail leaflet. So if the prolapse is not too large, and especially if it's not a flail leaflet, I think I would leave it with one clip. With a large flail leaflet, I would personally implant a second clip, even though the first clip has already a nice result just for stability.
Mehdi, you wanted to comment? Thanks, Raf.
I agree with what other panelists and what they commented.
Okay, maybe we'll just ask for folks to raise hand. Residual, let's just say that it's not a small amount of prolapse, it's moderate size prolapse residual, no significant MR left, no gradient. How many would put in a second device? Raise your hands, if any would. Okay, not a strong majority. What about those who would definitely not if the MR is gone to 0? Okay, nobody would say that definitely won't. Okay, so I think there's still some uncertainty here, and that's an area that perhaps we can do research. I want to ask perhaps our heart failure specialist here. In your mind, does it matter to you? Is it the MR? Would you worry about the prolapse? Would you ask the proceduralist to chase after the residual prolapse, or it doesn't matter? Don't have a strong opinion?
Well, for me, the primary issue, which is the mitral regurgitation, has been resolved. And what we're trying to do is reduce heart failure hospitalisations. We've known from our landmark trials that there's no benefit in terms of mortality. So for me, if the MR was resolved, I wouldn't have a strong preference either way, and I would leave that up to the proceduralist who was doing the procedure. If they thought they'd have a technical success and they felt more comfortable with it, I'd be happy, but I would leave that to the proceduralist, yeah.
Okay.
Okay, so I think we have to move to the next speakers. So let me introduce Dr. Ning-Yang Wang. So he's presented as tailoring TEER for Asian patients. So Dr. Wang, please.
All right, thank you for the introduction. It's great to be here in Tokyo Valves again. Let's have my slides. Okay, today I'll be talking about tailoring TEER for now the Asian patients. Okay, I'll start with a clinical case and talk about some challenges of TEER in Asian patients, as well as some of the Asian data that we have here for MTEER. So I'll start off with a case. So this is an 87-year-old male, pretty functional guy who still walks out in the community. He has not too many comorbidities, and he presented with pretty acute onset of symptoms, shortness of breath, and subsequently autopnea, as well as lowering swelling. And he waited around 3 weeks before he came to the hospital. And when he came to the hospital, he was tachypnic, and he had a harsh pansystolic murmur, and he was in heart failure. So he had an EKG done, it shows atrial fibrillation with rapid ventricular rate. He was congested, and that responded very well with intravenous diuresis. A transthoracic echo shows severe mitral regurgitation from a P2 prolapse. Left ventricular ejection fraction was 58. There was just mild LV dilatation, and the coronaries had just moderate LAD disease. So this is the transesophageal echo. It's a pretty classical P2 prolapse. I think the 3D anatomy shows nicely how the pathology looks. It's a pretty broad P2 prolapse. And you can see two torn cords sticking out like horns here at the 1 o'clock and the 11 o'clock position. And the P2 prolapse is pretty wide in respect to the mitral valve anatomy. You can see that visually it looks small, and the P2 looks rather big, and it's causing severe mitral regurgitation. And if you look at this, is the 3D multiplane reconstruction. Yeah, if you cut across the P2 prolapse, this is over here in this plane here, you can see the P2 prolapse with the torn cord flying out. So we make some measurements. The posterior mitral valve leaflet length measures at 9 millimeters, but we have to be quite cautious because you see how it cuts here. Maybe part of the cord can be included in it, and hence I would say 9 would be probably the maximum length. The mitral valve area was measured at 3.6 cm squared, and inflow gradient is 6, but bearing in mind the patient is really tachycardic at a rate of 100 beats per minute. So in this case, maybe I'll stop here for a while. First is to ask the panelists, as well as anyone from the audience, how will you manage this patient? He's an 87-year-old, but pretty functional guy. Yeah, and this is the anatomy. We have surgery, mitral TEER. And if it's M-TEER, what kind of device will we use? And or maybe just medical therapy and see how he goes.
Okay, so thank you for a nice presentation. So 87 years old gentleman. So he has a small area, 3.63 centimeter square, and mean pressure gradient is over 6 millimeter mercury. So how do you treat this patient in your center? So please.
Well, so 3.6 is just a number, and then the cutoff of 4 is relatively arbitrary. So I wouldn't really put much of focus on the actual number. 3.6 in the context of other sort of like risk factors is small. For example, if you have mitral annular calcification, if you have a thickened calcific leaflet, subvalvular apparatus matter, because there are cases that you could see how the subvalvular apparatus is thickened, calcific, and those cases, even if you have a valve area of more than 4, we have seen elevated gradients and mitral stenosis. So that mitral valve area per se wouldn't really dictate your strategy here. The gap of that flail is not massive. The width of that prolapse segment, which looks like a P2B to me, is not massive. The subvalvular apparatus is moving relatively freely with no significant calcification. So I think I would offer this patient edge-to-edge repair.
Okay, Natalie?
I echo the thoughts of Mehdi. I think there's not room for medical therapy. The LV is normal. I'm sure they've aggressively diuresed as much as they can. So if it's technically feasible, noting that you're going to have a higher risk of an increased gradient across that clip. But if it's technically feasible, I'd be supportive of the interventionist.
Okay. Rafi?
The advantage of an XT clip would be to get an annuloplasty effect, but this patient doesn't need an annuloplasty. So I would actually use an NTW clip, and I think that should cause a good result.
I have same opinion with the NTW to minimize the pressure gradient increase. And considering his age, 87-year-old, the M-TEER, although we cannot get the very excellent result, that would be the good option for the patient.
Mm-hmm.
Yes, looking at this image, I think the annual size is very small, and well, I would choose the NT or NTW for the first clip, and it might not be enough, so I might need a 2 clip in a P2. One thing I'm cautious about is the P3 segment. It looks like it's bulging, and there might be another jet coming out after reducing the P2 segment. So that's another issue.
My opinion is due to a high-risk patient, advanced age, and then I chose the MTR. But our concern is small mitral valve area, and the target region is 2 point, medial, A2P to medial and A2P to lateral. Then we chose the 2 mitral clip. Then and I think that mitral clip XT and XT on A2P to medial and mitral clip XT A2P to lateral. But MVA is not sufficient. Then my first selection is XCW for A2P to medial, but residual MR appear not MR is not disappear. I changed to the XT to XT.
Mm-hmm. So Makoto and Yusuke will select the multiple clipping. So how do you think about the pressure gradient after the so what is the limit of the mitral valve pressure gradient? So Yusuke?
The mean pressure gradient is due to MR. I think then MR reduction is MR reduction decrease the risk of mitral stenosis. Mm-hmm. Then I chose the to disappear the complete MR reduction. I chose the 2 clip.
So how much level do you accept the pressure gradient?
About 5.
5. But in this case, for primary pressure gradient is 6 millimeter, right?
So it was 6 millimeters mercury, but the heart rate was 110. Yeah. Okay. Severe mitral regurgitation.
So the mean pressure gradient across the mitral valve, as you would imagine, is not a reliable measurement, especially in the context of severe MR, and basically it's heart rate dependent, volume dependent, and I would put much focus on the valve area itself for screening, and also after putting the first device in, the gradient is a marker we use, but again, for those cases, I would also use mitral valve area to dictate the strategy whether the second device goes in or not. So just be careful about the mitral valve mean pressure gradients because it depends too many factors.
Okay.
Just to push that question on gradient a little bit, if you had a good result with MR reduction, it's clearly 1+ or less, what gradient would the panelists accept? I mean, it's always a bit of a headache. So Dr. Yusuke said 5. What about Makoto?
Well, depending on the MR reduction.
If it's down to 1+.
1+, then I would accept, well, ideally it's less than 5, but I would accept if until 7 or so.
Maybe?
There are a few points there to consider for me. The first thing is heart rate. If at the end of the first device, the heart rate is like 80, 90, that gradient is not reliable. I would bring the heart rate down. Majority of these patients have AF, and there's RR variation, interval variation. So you have the short RR and the long RR. So essentially, if the patient is sedated, GA, my personal approach is that I take the worst case scenario. So I take the shortest RR interval to see what the worst gradient is. That might be indicative of the wake up, but you can also average it between those two. And then the third is the blood pressure as well. So all those hemodynamic factors in place, then you can make a decision. But again, I would really, about like 2 or 3 as we routinely have been doing mitral valve area. There are 2 studies that they have looked into this, a trade-off between the residual MR and MS. And there are 2 numbers that you can use for cutoff. In normal people, you say 1.5 square centimeters as the cutoff for MS, but in the context of HLH repair, there are 2 studies. One is a cutoff of 1.9, the other one is around 2. So that's the type of mitral valve area I personally take in the context of the gradients, and as we all know, residual MR, which we all know has the detrimental effect on the outcome. So it's a pretty actually, again, a team discussion, but not just purely and solely based on the mitral valve gradient.
I think Ralph had a comment.
It can be very helpful to see how the hemodynamics develop during the procedure. So once you put in the clip and the blood pressure goes up or the cardiac index goes up, depending on what your anesthesiologist is measuring at that moment, then I would actually accept a higher mean gradient. On the other hand, if the blood pressure goes down, then probably even a 4 millimeters pressure gradient would be already too high. So this can really help to decide.
Okay, so the mobility of the patient, it depends on the acceptance pressure gradient. So one.
Okay. Yeah, so I think most people agree that this is a very functional 87-year-old that, and I think it's high surgical risk, and hence we give him an opportunity for a minimally invasive procedure to help to improve his quality of life and make him feel better. And his mitral valve anatomy is amenable, but I think the discussion is what device to use and what kind of gradient that we can accept, and hence we went ahead with MTR like what everyone suggested. So, transseptal puncture in the Asian population, as we can imagine, the atrial sizes are smaller. So we don't have that much room to maneuver. And hence, the usual height that we say, we want to get at least 4 centimeters, we almost never really get 4 centimeters. So in this patient, we got kind of a mid between the superior and inferior, the mid. And looking at this view here, we are very posterior already. And even with that, we can only get a height of 3.6, which is now quite standard that we usually get there. And also, the left atrial size is quite small, so when we steer down, we have to be quite careful. It's not going to be just like some of us, we have to deal with Caucasian populations. You just knock down, and within 2 seconds, you're all the way down. But in Asia, we have to probably, go down, pull back the CDS a little bit, steer down a bit, pull back, and sometimes maybe even understraddle. And everything has to be echo-guided to make sure we don't injure the lateral walls. And we use a lot of 3D multiplanar reconstruction. I feel that it helps a lot, especially in constrained spaces, because you can have a very 3-dimensional understanding of how your clip moves. And our echocardiographers here always provide really nice 3D imaging to try and guide this procedure. I use an NTW in this case. When I opened the clip arms, I was quite glad I used it because it looks pretty big already in this anatomy. Yeah. And using, if you look at the bottom right image, using 3D MPR, I position it centrally, maybe slightly medial, yeah, and you can see the leaflets nicely landing on the clip arms. And so, proceeded to grafts, and I think Dr. Makoto rightly picked up the challenges of this anatomy is that bulge behind, yeah, that made it actually pretty difficult to graft. There's a very hook-like posterior leaflet, and the bulge there makes it pretty difficult to get the leaflet well inserted. And this is our first graft. Pretty decent result in terms of MR reduction. But this is how it looks. I think most people may not really, some may accept this, but the excess redundancy makes me quite uncomfortable in the posterior leaflet. And hence, we try to optimize it by biasing the clip closer towards it and try to grasp. And to be honest, still not very satisfactory. And that posterior leaflet hook makes me want to keep optimizing and trying to get better. And finally, we got this, yeah? And I think it's quite much better inserted, yeah? But this is how it looks. I would like to ask the panelists, would you all accept this and release this clip? Or would you make any further optimization to it?
So Yusuke, would you accept this?
acceptable result, but I additional clip lateral of the A2B2.
Wait, what's the gradient? You didn't tell us the gradient.
Gradient was around 4.
4. Okay, would you
Yeah.
put the second clip?
Second clip.
Second clip and which one?
NT.
NT. Okay. Makoto.
Well, 90 years old, was it?
87.
87 years old. Well,
Not-
depending on the activity. If she's very active, then yeah, I might go for it. But if she's not, then I'll leave it there.
Do-yoon.
I would stop here.
Okay. Rafi.
So it really depends a little bit on the anatomy. If this is a good leaflet insertion, I would actually be happy with it. But you could actually try a second clip, and you can still take it out if you see the gradient goes up too far. So both options are open, I think.
87, significant reduction in the MR, mean gradient already of 4, I would leave it.
LA pressure and pulmonary vein flow reversal. If it's completely normalized and LA pressure has come down, at this age, I would stop. But if the pulmonary flow reversal present at the beginning and not normalized, and as you mentioned, the patient is fully mobile, I might consider the second one.
Yeah. I can't remember the LA pressure, but the pulmonary vein was dominant, systolic dominance.
So I would stop because you have the physiology back to normal, 86, and I think this we all agree is mild. So probably stop.
So yeah, I was struggling with this case, and I was thinking whether I would go ahead with a second clip, considering that it was very challenging to put this first device to actually have an adequate grasp of the posterior leaflet. So after released, the clip looks like this. It's still attached, yeah. It's still well inserted, still very secure, but there's just a lot of mobility. And this is how it looks after releasing the device. There's still some mild residual prolapse lateral to the first clip, and the MR is mild, and the systolic, the pulmonary vein systolic was dominant, so no doubt it's mild MR, but there's still a residual prolapse there. And the gradient was 3 here after releasing. Maybe I'll just move on, is that I think we have discussed this. I was uncomfortable with the remaining pathology. I went ahead to put a second device. And considering how difficult it was to get that posterior leaflet in because of the hook leaflet, I should listen to Yusuke, yeah, and use a long clip, yeah. So I use the XT now, yeah, and when lateral to it, it was really easy, yeah. And you can see the leaflet insertion all fully inserted, and grabs posterior leaflet. And the beauty about it is that we can don't release it and assess the gradient and see whether we're happy with it before we release the device. And so MR is abolished, yeah, and the gradient was 5 at a heart rate of 85. I thought it was acceptable, yeah, and released the device. And after releasing, both clips are very stable. And 1 month later, he was back to the community, still no MR. I beta block him really well, such that his heart rate is 56 now, and his gradient is 4 millimeters mercury, and very stable clips, and is doing well for this 87-year-old. So I'll move on. I mean, some of this, the challenges that we face in TEER in Asian patients is that some of these challenges are the transeptal puncture, the left atrial size, as well as the mitral valve area. And in most cases, you know, we want to have like a good height, you know, at least 4 centimeters. For DMR and medial pathology, we can accept something, we want something higher, but for FMR and lateral pathologies, we can accept somewhat a lower transeptal height. But in reality, in Asian patients, we frequently get less than 4. But there are maneuvers that we can gain height with the A-knob, and then subsequently some maneuvers to make sure the trajectory and position is adequate. And there are studies that show that the atrial size is truly smaller in Asian populations. In this population study of over 2,500 patients who underwent CMR, the Asians have smaller left atrial volume index compared to their Caucasian counterparts. Similarly, in this single center study, where they control matched patients from South Asian origins with Caucasian, also MRI study, the LA volumes are smaller, as well as the LV volumes are smaller in this healthy population. So as I mentioned, left atrial steering will be a little bit harder and a little bit more cautious, but still very doable. Everything echo-guided to avoid injuring the lateral structures. Try to gain every inch of space by retracting the clip during medial deflections. Sometimes we may have to accept that the CDS is not fully straddled. Yeah, we may have start doing an M-knot, moving a little bit, M-knot, moving a little bit, and 3D NPR is very critical to help to move in confined spaces. Then how about the mitral annulus? There are also studies that shows that the mitral annulus in Asian population is smaller compared to the Caucasian counterparts. And then we discussed quite a lot about this elevated inflow gradient. Is it okay? There are many studies looking into it. And I would say the data is pretty conflicting. Let's look at the primary MR data for elevated inflow gradients. There are some that says that, hey, an elevated gradient is acceptable.
Okay.
Outcomes are similar. There are some that say that it's not okay, yeah? The outcomes are worse with gradients that are high. But if you look carefully at what they define as an elevated pressure gradient, those that accept that it's okay, the gradients are actually pretty modestly elevated. One of them, the highest quartile, was the mean was just 6 millimeter mercury was considered elevated. Another study used more than 5, and the mean was 6.7 to 7. And those that are not okay shows that gradient of more than 4.4, more than 5, and already is associated with adverse outcomes of heart failure, hospitalization, and mortality. So we still don't really know. How about secondary MR? There are also publications that say it's not acceptable, some that say it's acceptable. If you look into it, like the COAPT study, where they look at patients who are mitral clip treated patients, and they use the gradient, the final gradient, and see whether it's associated with adverse outcomes, you find that even with elevated gradient, it was not associated with worse outcomes in terms of mortality or heart failure hospitalization. And if you look at the graph there, for the fourth quartile, the mean gradient was 7. Yeah, so they accepted that, and that was not associated with worse outcomes. But the Ocean Mitral Registry had a different outcome in that, and they find that in the Japan population of FMR treated with M-TEER, for every 1 millimeter mercury increase in gradient, it was associated with worse outcomes. Yeah? And when they grouped it into different groups based on the reduction in MR as well as the N gradient, they find that, of course, if you have severe MR and gradient more than 10, you do worse. That's a given. But for group 1 and group 3, when you have a residue of mild or moderate MR, as long as your gradient is less than 5, your outcomes are pretty similar. So we still have this conflicting data even for the FMR population. And if you look at a more contemporary data, one of the contemporary data is the expanded registry, 1,700 patients, both a combination of degenerative as well as functional MR. 1 year all-cause mortality and heart failure hospitalization were lower for those with MR 1+ or less, regardless of the inflow gradient. But however, elevated inflow gradient, once again, was also very modest, was just more than 5, mostly 5 to 7, and only 3% had a gradient of 8. So why this conflicting data? The mean pressure gradient is such a has so many variables affecting it, like what Dr. Mehdi and many of us have mentioned. The transmitral flow increases. When you have increased flow, you have increased gradient. Patient is tachycardic, patient has septic, anemia, all this can increase the gradient. The mitral valve area, the smaller the area, the higher the gradient. But it's not just these two. You have also the diastolic filling time. Where you have a shorter filling time, you have a higher instantaneous velocity, you have a higher gradient. So you see patients with small valve area, they don't tolerate tachycardia, they don't tolerate atrial fibrillation with rapid rate very well. Then there's also other things that are very difficult to measure. The left atrial pressure, the compliance. How about left ventricular diastology, the compliance of it? All this matters, and it helps, and it affects the gradient. And this was also mentioned, it's also the valve geometry and the flow dynamics. There can be calcification, there can be commissural fusion, there can be caudals that are calcified, and the remaining orifice, whether it's a funnel shape, whether it's a slit line, all this affects the flow geometry, and that may have an impact in terms of gradient. And the gradient is also just a number. There's also the clinical response and the clinical goal for the patient. If this patient is someone with recurrent heart failure admissions for severe MR, but he doesn't really walk much out there, maybe we abolish the MR and accept a higher gradient is okay. Or but someone who is younger, who's going out there, moving around, we may not be able to accept a gradient of 7. Yeah? So it looks a lot at the clinical goal of the patient. And also how the patient responds to the gradient is also a little unpredictable. And hence this area of mean periodic gradient is so difficult to really come up with a conclusion. So I will summarize to say that the balance between the residual MR and the inflow gradient is still going to be a challenge for MTR. But I'll say the studies have shown that the MR reduction still takes priority. We still aim as low a gradient as possible, less than 5. But we may accept a modestly elevated gradient as long as the trade-off is excellent MR reduction. And keep in mind the clinical goal for the patient and what we want to achieve for this guy. I'll just move on a little bit more about now some of the Asian populations. Looking at the EXPAND G4 Japan sub-study, the patients have smaller valve areas, smaller LV volumes, and as such, you can see that the clip selection, the different clip selections allow us to tailor to the correct anatomy, and you find that there are less XTW clips being used, more NT, more XT, but the results are still excellent. And if you look at the Ocean Mitral Registry, they look at patients based on the mitral valve area. They group into 3 groups, those less than 4, those less than 5, and those more than 5, and even those with very small valve area of less than 3.5. And you find that this valve area doesn't really affect the clinical outcomes of the patient because we can tailor the anatomy with the different clip sizes that we want to use. But we do notice that those with smaller valve area had slightly worse functional status, and that comes into question. That comes into the picture of what's our clinical goal for the patient: to reduce heart failure hospitalization, but maybe they may not be so mobile. And finally, I'll just show some data from this mitral and tricuspid clip Asia Pacific registry, where it's a real-world experience looking at mitral clip and tri-clip in the Asia Pacific region. Yeah, and you can see there are multiple centers in Asia, from Korea, Japan, Taiwan, Hong Kong, Australia, Thailand, India, Malaysia, and Singapore. And Professor Yeo is the PI for this study. There's an Echo Core Lab and an Abbott Supported. And this is a very challenging registry because, as you can see, Southeast Asia is very broad, very wide, each with their own regulations, and to get this trial going, it's a lot of support from Abbott. And we have some early data, yeah, and over 300 patients that we have here. These are some of the data that we have, and it's pretty similar to what many other studies have shown. These are elderly patients that we use the mitral clip in real world, 80 years of age, and the functional MR group, as expected, has multiple comorbidities, both CAD, MI, PCI, bypass, atrial fibrillation, diabetes, as well as dyslipidemia. And the type of etiology that we face is quite equal in terms of degeneratives as well as functional MR, both around 40%, and there are some that identify as atrial FMR in around 15%. And the clip type being used is very similar to that of the EXPAND G4 Japan sub-study. Yeah, it's almost quite identical, to be honest. Yeah. There are less XTW being used and a lot more XT, and the narrower clips are being used a lot more. And that we have a 30-day results is that the MR reduction is excellent. 2+ or less is 96, MR 1+, 70%. And for both the degenerative and the functional components have pretty equivalent results. And patients derive symptomatic improvement, and both for the DMR and the FMR group, and not surprising, for the FMR group, usually their symptom improvement is probably lesser compared to the degenerative because they're not just the mitral valve pathology, but also the LV dysfunction. Mortality was low, 3%, 30 days, and the SLDA rate was only 1.3%. So in conclusion, despite smaller mitral valve anatomies, the real-world experience and data have proven the effectiveness and safety of TEER in Asian populations. And the availability of different clip sizes allowed for a tailored approach to each patient's specific anatomy. And the balance of residual MR and inflow gradient will still remain a challenge for TEER, but the current data supports prioritizing MR reduction over modest elevation of inflow gradient. Thank you.
Thank you, Dr. Wang. So we don't have any time to discuss. So let's move on to the finaling of this session. So, ladies and gentlemen, thank you very much for joining today's session, Mastering TEER, Guideline, Complex Case, and the Asian-Pacific Insights. So let me summarize the key message we hope you will take home today. So first, Dr. Maki talked about the European guidelines, new guidelines. So and although the guidelines said the importance of the earlier consideration of MTEER, but his presentation is a very end stage of the ventricular FMR. But he successfully treated the cases in the new concept of PA compliance. The number of 2.9 over 2.9 is a good responder of mitral TEER. And second, Dr. Enter focused on the technical challenges in complex anatomies. So he presented the very non-central DMR cases, nicely treated with XTW. And the versatility of the mitral clip G4 system, I mean the control active grasping or variety of clips, so can improve our procedure success in those challenging cases. So finally, Dr. Wang talked about the central DMR cases and very small anatomy and the very high pressure gradient, but he is nicely treated with the case and the two clips, NTW and XT. And he also presents the MAS2 trial on the Japanese Expand G4 trial clinical study. So in the end of all three lecturers from Maki Sensei, Enta Sensei, and Wan Sensei, their point converge on the same principle, treating the right patient and at the right time with the optimal technical approach. So we hope today's session will support your decision making in your daily practice and ultimately benefit your patient. Thank you very much for joining us. Thank you.